The next speaker is Khaled Ezzedine. He is a doctor, professor of dermatology with a doctorate in epidemiology. His major areas of interest are pigmentation disorders, including vitiligo and ethnic skin disorders, skin aging, and the construction of a quality of life scale. He has written over 220 scientific articles, book chapters, including nearly more than 200 publications in PubMed. He has been associate editor of the British Journal of Dermatology in the epidemiology section since 2015. Today, he will talk about facial self-assessed VES is reflective of global perception of severity in vitiligo patient. Please.
Thank you, Dr. Bay. I'm presenting the results of my PhD student who worked on the face involvement of the SA-VES. Facial involvement is a reflective of global perception of extent in vitiligo patients. So the rationale for this is that patient-reported outcomes are used for clinical informed decisions, and more, and probably that the agency will ask in the future that we use them. The SA-VES, the self-assessed vitiligo extent score, is a simplified patient-oriented version of the vitiligo extent score, and it assesses the extent of vitiligo in different body areas. So this is the SA-VES that have been published by Nanja van Geel. And you can see that you have the face, but you have all the areas that are represented. So one of the main challenges that researchers and clinicians face when you interpret the patient-reported outcomes is to correctly identify whether a change in the score is relevant or not. If I'm just changing my score of, I don't know, 0.01, is it relevant? The minimal clinical important difference has been defined as the smallest difference in the score in the domain of interest which patients perceive as beneficial and which should mandate, in the absence of troublesome side effects and excessive cost, a change in the patient management. Minimal clinical important difference represents a threshold value of change in PRAM scores and is considered to have a clinical significance for the patient's perspective and can be used by a physician as a criterion for the effectiveness of a treatment, for example, and probably that a score like the VNS in the future will be used. So this study has two aims. The first aim was to determine the minimal clinical difference for the SA-VES, but not a global minimal clinical detectable change, but something for those who improved. We divided it in two. Maybe the improvement is not exactly the same than the worsening, and we found that it was not exactly the same, in fact. Second, we aimed also to assess the importance of the involvement of visible areas, the face and the hand, in patients' perceived change in the extent of their vitiligo. So how did we come to that? We have a cohort that is called COMPARE. COMPARE is a cohort, it's an e-cohort. It's a nationwide cohort of 50,000 patients with chronic conditions. And in this cohort of chronic condition, there is a specific cohort for vitiligo that we have created. And within this e-COMPARE cohort, this specific cohort has been set up in 2007. It's still ongoing, still recruiting. We have now more than 800 patients involved in this cohort. This is COMPARE, just to show you the advertisement. It's something that is funded by the French Ministry of Health. So participants in the e-COMPARE cohort are recruited by researchers involved in the cohort through media platforms, mainly myself, the team of Julien Sénéchal in Bordeaux, and the team of Thierry Passeron in Nice. We use pastors in hospitals and clinics, patient association, and snowball method to recruit the patients. And for each patient, we get the socio-demographic information, the vitiligo history, and all of those things. And in addition, we ask the patient questions related to quality of life, stigmatization, depression, anxiety, and others. So this study combined data from the SA-VES when the patient entered the cohort and the SA-VES 1 year after. And in addition, when the patient responded 1 year after to the SA-VES, they were asked to answer an anchor question that was since the last year, do you think that the extent, the affected area of the vitiligo is much more important, slightly more important, equivalent, slightly less important, or much less important? Since the degree of variation depends on direction of change, data from the anchor question were used to divide the sample into two subgroups, as I told you. For worsened patients, we took those who were slightly more important or much more important extent of their vitiligo, and we compared them to those who said we are equivalent, and for those who improve it, we did much less important, slightly less important versus equivalent. And we had a second aim, and this is for the second aim, to evaluate the association between the involvement of face and hand and patient perception change in the extent of their vitiligo. We did this through an ordinal logistic regression to estimate the association between the degree of the perceived change in the extent of the vitiligo using the anchor question, and we adjusted this for the SA-VES of the remaining body parts, of course, because if you don't adjust, then you are measuring the global perception of change. You have to adjust. 244 vitiligo patients answered the SA-VES twice at 1 year interval. The mean age was 51 years. There was a majority of female and a majority of fair-skinned individual, which is probably one of the limitations of the study. And the median IQ error of total SA-VES at inclusion were 4.78. So the MCID for worsened patient was equal to 0.247 for increase, with a sensitivity and a specificity that are not extraordinary but are not that bad. This is the ROC curve. The same, we did the ROC curve for those who improved, and the improvement, it seems that a minimal change had a maximum perception of improvement, 0.21 instead of 0.24. For the change in the involvement between T0 and T1, we found that hands are not significantly associated with perceived change in the extent of the vitiligo, but this is not really surprising because usually hands respond very, very poorly to treatment. On the contrary, for the face, we showed that an increase in facial extent was significantly associated with the perception of deterioration, with an odor ratio of almost 8. So this is the first study that assessed the MCID of total SA-VES among worsened and improved patients. There was another study that did the global MCID for SA-VES. We were able to show that facial SA-VES can give a global impression of the course of vitiligo as perceived by the patients themselves. We think that a further evaluation on larger sample size is needed to be able to detect smaller perceived changes. And developing new patient-reported outcome measures for assessing the implementation of the face is of high interest, as in our study, patient perception of their facial patches was of most importance compared to other body parts. And you know that this is really something that we should all work on, because the face now is being measured for most of the trials that are ongoing, and ultimately, this global impression of extent, we hope that it could correlate with an improved quality of life. And thank you for your attention.
Thank you for your talk. This study is very relevant and very important, I think. I have one question for you. Based on your data, patients perceive the tiny change of 0.2 BSA in their face. But I'm a bit curious of whether...
No, not on the face, total body.
Yeah, okay. I'm a bit curious whether self-assessed BES capture the small change, because it divides extent into only 6 scales, especially in the face. So I think we should need more scales in the face.
Yes, this is one of the conclusions of the study, is that probably we should create something specific for the face because it's much more easy. This is exactly the conclusion of the study. I agree with you, and it will be much more easier probably if we focus on the face, and this is what the industry is doing now. But don't forget, because I think that we didn't found that the hands are something that is related to the perception of extent, but we were in a European country with not a lot of patients with dark skin, and I think if we want to validate this, we need to replicate the study in several countries, and again, the interest of doing registries and doing things in several countries. It's not only in Europe, because in Europe it's quite easy, because during the summer you can see the vitiligo in fair skin, but during winter you don't see anything on the hands. You mainly see it on the face. Yeah.
I agree with you. I think that these patients probably should. Many of my patients who are light-skinned don't even know they have it in certain parts of the face until I showed them with the Woods lamp and a mirror. So that's one limitation that maybe can be overcome in this particular study. But the other thing I want to mention is I'm amazed at how many people say that their hands are worse or better, and then when you pull up their picture from 3 months ago, they're wrong. It was already there. But the face, they are more accurate, in my opinion, in being able to judge if they're worse or better. That's just my own experience.
But it's exactly what the study is saying. It's exactly what the study is saying. It's very difficult to get twice a score. Very, very difficult, honestly. And the paper is under revision, and the statistical editor of the BGD has made very good remarks. We're trying to see the distribution, the normality, because you haven't seen, but maybe Youngmin, you have seen that the intervals are quite wide. So we're trying to normalize the curve and get better result, improve the rock, and see what happens. But I think it's just a first step to go and to validate probably the facial VASI and to validate a score, a patient-reported outcome score like the VNS. But the VNS, you know what I think about it. I think there are things that are not really validated in the VNS. But really, I think that we should all work on a specific score, specific patient-reported outcome measure for the face.
And the MCID is so important, because that's going to help us determine if a treatment is actually effective or not in the patient's point of view.
Yeah, I agree. And it's important also to see the MCID for improvement is very important for clinical trial, and the MCID for worsening is very important in clinics, in daily clinics.
Yeah, with the time limitation, we can have only one question. Okay.
Thank you very much.
For a great talk.